The idea that you can't find out what something is going to cost before you agree to it is outrageous. Name any other industry that refuses to show you a price. It is incredible to me that we are still fighting about transparency when it is 20% of the US economy. This is a multi-trillion-dollar industry who feels no accountability to show pricing.
Welcome to The Other 80. I'm Claudia Williams. While our outcomes don't reflect it, the United States spends the most on healthcare in the world. Healthcare affordability is a huge issue for many Americans in their daily lives and at the voting booth. So, of course, there are many reasons to rein in healthcare costs, including to free up resources for more of what we know is effective to build health in America: social supports, prevention, and a focus on health in communities. California is tackling this issue head-on by setting a 3% cost growth target for the state. Elizabeth Mitchell sits on the advisory board that set the new target, and she joined me to talk about the nuts and bolts of the new policy and the strategies employers are using to try and make healthcare more affordable in the U.S. Please welcome Elizabeth Mitchell to The Other 80. Hi, Elizabeth. It's so awesome to have you on the show. We've known each other for several cycles of different identities, so we'll cover some of those as we go forward. But thanks so much for joining.
I'm so glad to be here.
I always start with a question, which is, what is important for our audience to know about you?
That's a hard question. Well, I have this unhealthy obsession with trying to fix healthcare. I used to work on behalf of, unions and employers, and you'd go out literally on a shipyard and talk to the welders about not being able to afford their benefits. And that was 20 years ago. It has only gotten worse. And you think about the human impact of the affordability crisis, and it just makes it real. And I believe all of us who are in a position to lead change have an obligation to do that.
I pulled some of the latest stats from the Kaiser Family Foundation survey. So I'll read out some of those related to this question of the pain that's felt so broadly across the United States. 75% of respondents worry about unexpected bill or cost of health services. And it's that quality of a surprise around the corner that could uproot your lives. 60% skipped or postponed care due to cost, 60%. That could be splitting pills. That could be not getting something prescribed. That could be not showing up when you need a doctor's visit. And 40% have medical debts or bills. And so we're not talking about something affecting 10% at the margins. Every single one of us has a story from our family about something that happened. And not just the routine costs, but the unexpected issue that causes bankruptcy, that causes people to lose their homes. And I know part of what you've been doing over the last year or two, and we'll talk later about the important advisory body you sit on, is hearing the stories of Americans, of Californians. Do those stats represent what you've been hearing, and what are some of those stories that really rise to the top for you?
To be honest, as bleak as those statistics are, I think they sugarcoat the actual reality of it. And also, some of the statistics you used are for people with insurance. This used to be for the uninsured. Now it's for people with insurance still can't afford care. And the data is showing that people are avoiding care that they need because of affordability. It's the number one barrier to access. So when we talk about wanting accessible care, you have to tackle affordability, not to even mention equity. And what has been, I think, so powerful about the Office of Healthcare Affordability board meetings is that they are public forums. There are not a lot of public forums where you can discuss issues like healthcare affordability. I mean, people rant about them online, but to truly have the people who are impacted take a day off of work and come to share their stories, and they are heartbreaking. We heard about a woman whose husband was admitted to the hospital. I think it was for like one day. And the bill was so high, they ended up not being able to pay for their car, which meant they lost their jobs, which meant they lost their homes. It's just this cascade of burdens on families. Another guy he was a young single father, and he had another hospital bill, unexpected, as you said, couldn't pay it, had to take 3 jobs for a year. And he said he only saw his child once a week during that time because he was working to pay off that bill. And when you think about the things that contribute to health, and I know your podcast focuses on the other 80, contributing to health. Well, this is sort of the opposite of that. Stable housing, employment, financial security, mental health, all of the things that we claim we value are being absolutely undermined by having an utterly unaffordable, unresponsive healthcare system.
We've been touching on out-of-pocket costs, right? But I think what's important to remember is that's the canary in the coal mine for overall costs. So while those costs are going up, the overall costs are going up in full step with the out-of-pocket costs. And I think there's a lot of bugaboos. Like people are like, it's the health plans, those rich, CEOs of those guys, it's the pharma companies. But when you actually have dug in and looked at the data, what explains the high and growing costs of healthcare in America? What are the biggest factors that are really driving that?
Well, unfortunately, it's kind of all of the above, right? It's hospital prices, it's drug prices, it's administrative costs like PBMs and health plans who are adding significant cost for the administrative work. It's all sorts of things. Yes, it also is chronic disease, it's cancer treatments. There's a lot of drivers that add up to the total, but pricing and administrative costs are among the top of the list, and drug cost. I would say, sort of on the flip side, Arnold Milstein at Stanford is our chief medical officer and founder of PBGH, and he's done a lot of research on what actually brings costs down. And there's not a lot, but advanced primary care, whole person primary care that includes behavioral health, integrated behavioral health, that's one. And effective specialty referrals, not referring for inappropriate or unnecessary care and referring to the top quality specialists. Those are two strategies that absolutely reduce cost by keeping people healthy. And we've actually proven that in our own work. The California Quality Collaborative, which is part of PBGH, has done incredible work working with practices throughout California, even small rural practices. And with support and with data and the right teams, they have been wildly successful at keeping people healthier, first of all, and then avoiding unnecessary hospitalizations and ED visits. So keeping people healthier and also saving hundreds of millions of dollars. So we know it's possible. It has been done, but it hasn't been scaled. And that's what we need to understand. Why aren't we doing this as a system?
And I think that points to what we've seen is that the physician-driven Medicare ACOs have been quite successful where they have access to technology and to smart referral networks, whereas the hospital-driven ACOs have not been the money savers that we had hoped they would be.
And it's not just the technology, it is the incentives, right? So if avoiding a procedure or avoiding a referral is going to cost you, you're less likely to do it. So the incentives are very strong. I had a board chair once who said it was a fool's errand to ask someone to work against their financial self-interest. And right now, that's what's happening. So we've got to change the payment system. We've known that. We've been working together since the Obama administration looking at payment reform and new payment models, but they just haven't been implemented.
Before we move off this question of the drivers, one of the facts that's often surprising to Americans is when they think of national health systems, like in the UK, they often assume that that comes with less access to care. And while you might argue that access to the most highly specialized or technologically driven care might be less in some of those systems. What we actually see when you look at the data is higher use of primary care, more visits to the doctor. And one of the big differences when you look at the US compared to other countries is how much we pay, not just our hospitals, but also our doctors. So obviously the things you're talking about are really valuable in bringing down the use of unneeded specialty care, but they don't get at this core question of the prices we pay. And that's not just the prices we pay for a service, it's also the salaries. Should that be part of the conversation as well? Or are you more in the place of saying there's so much other gains to be had, we don't have to start looking at the salaries we pay people in the sector?
Well, I actually lived in London for 5 years and did comparative research on the NHS in the US.
You
So that
tell
was
it. You tell
well, it's fairly
it.
dated at this point, but your point is really important because I also did field work there. I had 2 kids while I was there, and I was a user of the system, and the access myth that it is harder to get care in the NHS, I did not experience. That doesn't mean that there aren't limits and wait times, but anyone who's trying to get care in the US right now, unless you have some super high end concierge practice, you have wait times here too. Getting a primary care visit in California can take 3 to 6 months. So we talk about the access issues with a nationalized system, but we have similar, or if not worse, access issues here, but we pay much more for it. We also need to compare the outcomes because overall, the outcomes in the UK and many European countries are better. That doesn't mean we should move to a nationalized system, but it certainly means we could be spending a lot less and getting a lot better care.
One of the strategies that has been used by the federal government in particular is a big move to get hospitals to publish their prices. And for anyone who's tried to get a scheduled procedure like a mammogram or something and tried to understand a price, that's super understandable because the prices are complicated. Sometimes the hospitals don't even know the price of the service they're delivering. At the same time, when you talk to people in this field, I think the general feeling is that while that's a very logical move, yes, we should know the prices, it's not gonna actually have a big impact on the overall price trends or even on people's selection of where to go for services. Can you talk a little bit more about that so we understand that issue better?
Absolutely. First of all, the idea that you can't find out what something is going to cost before you agree to it is outrageous. Name any other industry that refuses to show you a price. It is incredible to me that we are still fighting about transparency when it is 20% of the US economy. I mean, this is a multi trillion dollar industry who feels no accountability to show pricing. So I just think it is incredible that we do not have meaningful transparency yet. The good news is there has been federal action. Sadly, it took federal action, but there is now, a requirement that hospitals post their prices, that increasingly we're going to have the negotiated rates with the plans and pharmacies. So we are definitely seeing progress there. In my view, though, transparency is necessary but insufficient. You are not going to change consumer behavior just by putting prices on a website because people don't make decisions about their healthcare just based on price unless it is a completely voluntary decision like do I need a lab test here or there or where am I going to have my baby when you have months to plan. But most of healthcare is not like that. And people care about quality. They care about patient experience. They care about things in addition to price. So it is necessary that we have it. Any functioning market has transparent pricing. It's not even a question. But it will require purchasers, both public and private, to use that data effectively to start reducing overall costs. I think Don Berwick said it is just unfair to expect a consumer who is sick with a $10 copay to change the healthcare system. They don't have any leverage. It is so complex. But when you have jumbo purchasers who can actually identify who are the high value partners, who are the high value primary care practices or hospitals or systems, and begin to steer their employees or families towards those better performing, higher value partners. That's when you start to see a shift. It's not necessarily about just using the higher value providers. I think it starts to put pressure on the entire industry to become more efficient.
So you are part of this important body that's advising the state of California on setting cost growth targets, and this came out of recent legislation. And we'll get to those targets themselves in a minute, but would just love to hear as a setup to that, what has your group been deliberating? What data have you been looking at? And what was the charge you were given by the legislation?
Sure. I actually was appointed to the board of the Office of Healthcare Affordability by the governor and confirmed by the Senate. And we are tasked with, first of all, setting a cost growth target for the state. We had to do that by June of this year, and we did that in our April meeting. But that was after over a year of very thoughtful and thorough deliberations, not only by the board, but by the various advisory committees that have been created. And we also, as I mentioned before, had public testimony at every meeting. Sometimes we would have hours of public testimony, hearing from folks on all sides, some who were supportive, some who were opposed. And that was just also incredibly important. We have been looking at the experience of other states who have created these affordability boards, learning from them. We have looked at data from IHA, the Integrated Healthcare Association, looking at trends over time. We have invited and heard from um, I would call them sort of the positive deviants, those who have been successful at reducing costs and improving health outcomes and learning how did they do that. You know, we heard from a health plan who had real success in maternity care. We heard from a health system who had reduced their cost by, really focusing on, keeping people out of the hospital in the first place by doing other sites of care. So really learning what does work and what the barriers are to change. So it has been, I think, a very, very thoughtful, very engaged board process. We had a 6-1 vote. We didn't get to unanimity, but I think there was strong consensus that the targets that we selected were appropriate and fair.
So talk about those targets. What targets were set? How's it going to work as it rolls out? And then we'll get to what's going to happen next.
The ultimate target will be 3%, but we felt that it was important to respond to much of the industry who said that that was too far too fast. So we did start with 3.5%, and it will be reduced over time to 3. There is sort of a graduated response embedded in the legislation where there can be first warnings, then performance improvement plans, and then ultimately fines for those who do not meet the targets, but that is several years out. I believe that a 3% cost growth target actually does not do enough to meet the needs of consumers. And I was quite vocal about that for the entire year of conversations because when you think about it, that's another 15% in 5 years. And that is not more affordable. But at the very least, it starts to hopefully change the trajectory of cost growth. And this is not going to be sufficient. It's not going to just take state action, right? We need all of the players in the industry to really step up and change care delivery. We do have a big emphasis on investing more in primary care. We have an emphasis on changing payment models because we know that, fee for service is a real barrier to optimal primary care. So it's not intended to be sort of a simplistic cap. There is a lot of thought to really systemic change that we know is going to be required.
So take us inside the mechanics of how this is going to work. When you say somebody gets a warning letter, who gets the warning letter? And what are some of the assumptions about how those accountable parties will react to this? What do you hope happens out in the field?
So I cannot say with specificity exactly how that will play out, but the different entities who are subject to the target include hospitals, include IPAs, include health systems, includes health plans. So it's most of the industry. The way that I see it playing out is I think there are going to be some facilities and some systems who have a much harder time hitting 3% than others, right? There are some who are very cost effective now, and there are some with double digit increases every year. There is going to be different levels of change required depending on the entity. I would hope that the leaders of these organizations take it upon themselves to find the best strategies to reduce cost because many of these are nonprofit entities, so they do have a community obligation. And we heard from many of them who said they are meeting that community obligation by investing in their communities and, supporting educational programs or housing programs. And all of that is great, but we still have the core challenge that healthcare is unaffordable. So it is going to require some significant changes to hit that target. But ideally, we would take that collective challenge upon ourselves and really learn what it would take to be successful. I would also say that there's going to need to be changes from payers, from health plans in terms of payment models, and maybe they're going to need to retool their legacy claim systems. Maybe they're going to have to rethink data sharing so we understand what the cost drivers are. And frankly, employers are going to have to change too. They are going to have to make sure that their benefit designs are optimal and incent the right care. We have several of our members doing that now. It goes without saying it will take change from everyone because this is such a big challenge. But I do think this at least sets a standard for where we all should be headed.
I believe it was Richard Pan that was the outstanding vote who did not vote to support.
It was.
What were the concerns that he was representing, and who were the groups who were actively supporting this, and who were the groups out in the community that were opposed?
Yeah, I really don't want to speak for Dr. Pan. We worked very well together. We served on a subcommittee together, and he had, I think, strong concerns about the feasibility. I would say that the groups that we heard from who were most opposed, I would say, was the Hospital Association. There was more of a mix among many of the health plans. Um, there were concerns from some of the physician organizations, but it was a range. But there seemed to be clear unanimity from the consumers, from the unions, from the teachers, the carpenters, everyone who showed up to ask for help with affordability. There was certainly consensus there. I would just say I do not know many people who think the healthcare system is working well for them right now. And that is not about blaming anyone. It is a collective problem. We heard from teachers and law enforcement and carpenters, so many people who simply can't afford the care they need for themselves and their families. And I just don't think we can ignore that. It is not a problem that is going to go away if we do not make systemic change.
Let's talk about your organization, Pacific Business Group on Health. Actually, you changed your name. What is your
Yeah,
name?
uh, low budget name change. Purchaser Business Group on Health.
Okay,
So
Purchaser
same
Business Group on Health.
acronym. Yeah, same acronym, but not regional.
What's exciting about this conversation is the potential role of the purchasers, the employers, who are, on the one hand, building businesses, bringing value to the market, hiring people, but healthcare costs is something that makes it hard for them to be competitive on the global stage, and also makes it really challenging to run just even a profitable business. So we have, I think, a strong alignment of interest where employers don't just want more affordable care. They, of course, want higher quality care. And they are hit by the lack of that on so many different dimensions, whether that's elder care or family members that are taking care of small children, or all of our just routine issues that come up in our lives. There have been some really exciting models for what an employer action can look like. But I think a lot of employers are like, this is not my core business. This is not really what I want to be focusing my attention on. I just want it to be better and fixed. And so you have this challenge where they're being asked to step up in a way that maybe is uncomfortable for them in their core function in society. So, as the organization that is rallying that force in the country, what do you see as some of those biggest opportunities for employer voice and action? And how do you, as the leader of an organization, help people get systemic change that can be shepherded in a way that doesn't ask the CEO to now make this their full time job?
It's a complete accident of history that employers in the US pay for healthcare, right? It came out of the Depression when there were wage freezes, and it was a way to attract talent. Now, employers pay for 150 million plus Americans to access healthcare, and they pay the entire profit of the healthcare system because if you ask any provider, it's not coming from Medicare and Medicaid. So, self insured employers who are my members are bearing the financial risk and paying for the healthcare system for an enormous number of Americans. And to your point, it is not their day job. They build ships or computers or sell groceries, and it is not something that they should need to have a core competency in, right? Like, why do they have to know how to run a health plan? Well, unfortunately, that's where we are. And I don't see the political will to significantly change that. So we are focused on enabling jumbo self insured employers to be as effective in purchasing healthcare as they are on anything else in their supply chain. You know, whether you're buying a computer part or a grocery, you need to know the quality, you need to know the price, and you need to have good service. So if we bring some of that procurement discipline to healthcare, I think we will start to make a pretty significant difference in the cost and quality of healthcare services for their workers and families. So, what do I mean by that? Well, unfortunately, or fortunately, I don't know, with the new transparency that is now available through the CAA, there is increased visibility into pricing variation, but also conflicts that were not known to employers. So imagine going to buy $6 billion worth of healthcare annually, which is, not unusual for my members, and having no idea what the prices or quality are. Like, just imagine that. So they've relied on consultants and brokers and health plans and PBMs and this sort of cast of, you know, folks who do that on their behalf. They enlist them to go buy healthcare for them. But what is becoming increasingly clear is that the plans, the PBMs, and the consultants all make more money when healthcare costs go up, right? It's just the incentives. I'm not blaming the actors, I'm talking about the incentives. And much of that was not really fully known because there was no transparency. With the transparency, we're starting to see wildly different hospital prices, as an example. And the employers can say, wait a minute, why am I paying 10 times as much over here than I am over there? And they can start to really dig into their own data and make very different purchasing decisions. So that is coupled with a policy change that went into effect in this year, beginning of this year, where self-insured employers are being held accountable by the Department of Labor to only pay fair prices for high quality services. So if they are responsible as fiduciaries, they've always had that responsibility. But now with this new transparency and with some tweaks to ERISA, they are now personally liable. They have the legal risk as well as the financial risk that they've always had to make sure they are expert fiduciaries of their employees' money. So they are being held to an entirely new standard that requires them to know the relative cost and quality, requires them to make sure they are not overpaying for drugs or tests. So there is a significant shift in the environment that is requiring new levels of engagement, but that is also being accelerated by the affordability crisis. Because to your point, it is one of their top spends. It is probably the second highest expense for their company is healthcare costs. Our members spend hundreds of billions of dollars annually on healthcare. So they are taking a very different approach to ensuring that they are only paying a fair price for high quality services. And the way we help them is, first of all, helping them define quality. So we have done years worth of work on quality measurement, helping them really clarify and articulate their priorities. They care about access, they care about outcomes, they care about experience, they care about total cost of care. So really clearly articulating employer priorities is one thing that we've done it. We've done it on advanced primary care. We've just released similar quality standards for maternity care. Then we're helping them really ensuring that those standards get integrated into their contracts with their health plans. So they are able to really see, are they getting really high value care for their employees? And then in many cases, when they are not satisfied with that approach, we are also helping them do direct contracts so that they can have a direct partnership with the provider and ensure that they are getting the care that they want for their employees and families.
You and I were both in the room at a recent conference where Mark Cuban spoke, and he
Yep.
minced no words about his lack of love for PBMs, which is sort of the equivalent middle body, middle person for pharmacy spend that some of these agents are on the claim side. And so it's interesting to wonder just generically if we might move towards a world where there are fewer of these intermediaries, or if the intermediaries had more aligned incentives around quality, around cost management, affordability, access, things like that. Because if it's just based on price and total spend, that is never going to align with your goals. I'm curious if you sort of see any shifting in who the players are that those employers might work with to help them reach those goals.
Well, I think that there are several new market entrants on the PBM front, on the TPA front, who are trying to offer an alternative. And let's start with transparency. You can actually see where your money goes. We are talking about very large companies here. They are not suggesting there should not be a profit for doing good service, but it should be known, it should be reasonable. And I mean, if it's a fair price, great. But so many of the incumbents are simply not transparent about rebates and all sorts of opaque pricing patterns that really make it very difficult to know if you are getting good value. And there are things in these contracts like not allowing audits. I mean, it's their money, right? So they should be able to audit their spend. And now I think the fair challenge to that is, so why do they sign these contracts? I think that is a totally appropriate question. And part of it is they are wildly complex and many times opaque, but that's not a justification. But then there traditionally have not been alternatives. The market is highly concentrated. There are about 4 or 5 entities that own all of this. The vertical consolidation is stunning. But as we start to see these alternatives and they start to get a track record and show the difference, I think you're going to start to see early competition.
I wanted to talk a little bit about social drivers and how that fits into the employer landscape. We've seen a lot of what I, for shorthand, call whole person care models in Medicaid, where we're looking at combining food support and housing services and companionship and other kinds of things to complement medical care. And we're seeing a burgeoning of that across Medicaid programs and also in many cases with duals programs that are serving both Medicare and Medicaid enrolled folks. But I am curious, when you talk to your members who are jumbo employers, how does that whole person care, social drivers conversation fit into their set of priorities?
I will tell you, all of our members, and I don't speak for all employers, but I speak for our members, want whole person care. They understand that it is everything from transportation to childcare to housing to environment that contribute to health. They know that. They are taking it upon themselves to try to create the availability of some of these social supports. Employers absolutely want to address those needs. There are not a lot of mechanisms for them to do that. There is no way a jumbo employer can go out and find every successful nonprofit in a community and support them. They can't do direct services. That's not their core business. So there is just a disconnect in what they want to be paying for, which are things that keep people healthy, and mechanisms to do that.
And I can imagine thinking about your strategies that one approach might be to say, listen, in the context where we're rolling out advanced primary care and where we're giving those primary care sites greater accountability and responsibility and tools, fitting this into that, and especially if there could be a partner that does some of that bundling of social services, that makes sense because you then have a context where a referral can occur, where the closed loop can occur, and where the needs assessment can occur versus fragmented off into some random person and the employer who's calling and saying, hey, do you need housing services? So I wonder if the right strategy is one where it's embedded in some of the other strategies and approaches that they're taking.
Well, I would strongly agree with that and suggest that primary care could be the home for a lot of this. We have seen some very successful primary care approaches with embedded community health workers, as an example, who follow up and go to the home and make sure that they have the food that they need. And they're doing social needs screening at the primary care practice. All of these things would help. But right now, primary care practices aren't staffed or paid to do this. So, how do we change payment to primary care to ensure that they have the resources they need to play a larger role in addressing social needs?
So I recently joined the Berkeley School of Public Health as the Chief Social Impact Officer. And the question in front of us is, how might a school of public health accelerate the changes that are needed in health with a particular focus to drivers within given communities for health or ill health, and how do we get ahead of those? This is not the way universities typically think, right? They don't think of themselves necessarily as platforms for change, as platforms for movement building, as places to convene the interested parties, right? They think of themselves as primarily focused on education and research. And so, my question for you is, what might be some of the most rich opportunities to seize that role for a place like the Berkeley School of Public Health?
What a great question. Well, I would say, first and foremost, help us know what best practice is, right? We're not doing research, but we really value the evidence of what works and start getting that into application. It's one thing to publish it in academic journals. Obviously, that's important, but that's not going to reach someone who's making day to day healthcare purchasing decisions. So, how do we bridge that and really learn what is most effective? Because that's a gap that can be bridged. Also, help us lead change. We are up against some very entrenched incumbents, and you have such a respected voice in the community. And we're not trying to burn things down, we're trying to make things better. So, being thought partners and leaders of change on behalf of the community, I think is really important. And you can be conveners because no one's going to solve this by themselves. So, how do we all get together and say, well, this is what I can do, this is what we need from you, and set a vision and make something happen?
Thank you. I love that. Great place to close out. Thank you so much for your time today. It's delightful to see you.
You too.
California was not the first state to set cost growth targets, and it won't be the last. I came into this conversation really excited about this new policy, but left, to be honest, with this troubling statistic in mind. Even if California is wildly successful in achieving its target, our costs will still be 15% higher in 5 years. That is 15% higher than what is already a massively unaffordable cost for many Americans. At the end of the day, we're not talking about lowering current costs, but just capping the amount those costs can go up. And is that really the progress we need? Is that really the best we can do? This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information on Elizabeth Mitchell and her work in California and across the nation. There's more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.